right, perfect. All right, well, I can't see you guys, but thank you for joining the Zoom call today to discuss female urinary incontinence. My name's Christopher Drew. I'm a urologist here at the Urology Center of Colorado, and I have subspecialty training in female urology, pelvic surgery, and things like that. There's going to be the ability at the end for questions and answers. I want to make sure I answer all your questions. If you have any questions, feel free to enter them on the question and answer tab or on the participation tab at any point, and then basically I'll start going through them at the near the end of the talk. So the main thing I wanted to discuss today was female urinary incontinence. And urinary incontinence is essentially the leakage of urine. So for today, we're going to go over the most common types of bladder leakage and then look at a lot of the treatment options as well. And I think one of the big takeaways I wanted to really go over today was the fact that a lot of women wear leakage of urine as really a badge of honor, whether it's through previous surgery or childbirth, or just the thought that this is what's supposed to happen as I get older. It doesn't have to be that way. And there are a lot of treatment options available that are really, really easy and can get you dry very, very quickly. So as I mentioned, bladder leakage is the same thing as urinary incontinence, and that's the loss of bladder control or involuntary loss of urine. And it affects millions of women. So around 18 million women in the United States, adult women, have some form of incontinence. That's almost 1 out of every 2 women. Now, I want to go through the different types of leakage because this is really what decides what the best options are. So there's really 3 main types. The first type is what's called urge incontinence. Urge incontinence is the type of leakage where all of a sudden, out of nowhere, you have the urge to go, you rush to the restroom, and you can't make it in time. And there are a lot of social implications because it can be embarrassing. People change their lifestyles around their bladder, and our goal is to make it where you don't have to do that. But that's really the unintended loss of urine. Now that's in contrast to what's called stress incontinence. With stress incontinence, there is some form of stress to the abdomen or the lower belly that causes increased pressure, and then there's loss of urine. So this is the type of leakage where a woman will come into my practice and they'll say, when I'm doing Pilates or I'm jumping up and down or I cough or I laugh or I sneeze, I leak a little bit of urine. Is there a way to fix that? So that's what stress incontinence is. And it's very different from urge incontinence, not so much in the urine, but in how we treat it moving forward. The third most common type is what's called mixed incontinence. Mixed incontinence is really a combination of both those types. So for any woman that comes in to at least my practice, one of the first questions I ask after I get to hear your story is, what percentage of urine comes out from the stress component and what component is coming out from the urge component? Because that really dictates the treatment options. So as I mentioned, about half of adult women have some form of leakage. The stress incontinence is really the most common type, about 50%. A quarter of women have pure urge incontinence, also known as shy bladder or overactive bladder. And then lastly, about 1/4 of women have a mixed component. So urge incontinence, as I mentioned, really described by patients as needing to go even if they just went. And it's associated with overactive bladder. So typically getting up at night, more than once, or that strong or sudden urge to urinate are some of the hallmark characteristics of urge incontinence. Now, stress incontinence, on the other hand, that's the pure loss of urine during any movement. So for example, exercise, where there's jumping up and down, there's some form of stress to the abdomen. Coughing, laughing, sneezing, some of the most common reasons that we see stress incontinence. Jumping on a trampoline or lifting heavy objects. Now, stress incontinence really comes in 2 different flavors. There's what's called urethral hypermobility or intrinsic sphincter deficiency. So hypermobility really occurs when the bladder or the bladder neck and urethra are no longer supported. And the bladder neck and urethra may even move farther down into the pelvis with cough or laugh. This is pretty common after childbirth or really pelvic surgery. If you think of the pelvic floor like interlaced fingers, what happens is when you have a baby, that pelvic floor stretches. And when it stretches, it loosens the support for the urethra. Now, in contrast, intrinsic sphincter deficiency is really the lack of the ability of the sphincter muscle to keep the urine in. As women get older, a lot of times estrogen levels will decrease, and estrogen is directly related to the bulk and the health of the urethral tissue. So actually, for most women with urethral intrinsic sphincter deficiency, topical estrogen can actually be really helpful, and we'll get more into that later. With stress incontinence, moving forward before we talk about the treatments, I want you to think of the urethral stress incontinence almost like a garden hose flapping around in your backyard. And if you would go over to that garden hose and you step on it, if you're on a muddy surface, that garden hose is basically gonna sink right into the mud, and the leakage is gonna continue. And that's really what having a poor pelvic floor support is all about. Now, on the other hand, if you have good pelvic floor support, which can actually be helped by some of the procedures I'll discuss today, when you go to step on that hose, it's almost as if you're stepping on that hose on a firm surface. So when you go to step on it, you'll be able to stop that leakage. There are many risk factors for stress urinary incontinence. Two of the most common are really age and then menopause. Menopause really because of that lack of estrogen that helps bulk up the tissue. We also see it in pregnancy because that pelvic floor that I was talking about gets stretched, and that stretching decreases the support. We also see that through vaginal childbirth. Previous pelvic surgery, so for example, hysterectomy or any other type of pelvic surgery, weakens those muscles and it can increase the risk of stress urinary incontinence. Being overweight or having an elevated BMI means more pressure in the belly. More pressure in the belly can translate into stress incontinence. So weight loss is actually one of the best things that we can do to help this. Physical activity and heavy lifting, again, increasing forces in the belly can increase the risk of incontinence. Smoking causes atrophy and poor oxygenation of tissue. So we see stress incontinence as in relation to smoking. Less likely genetics and family history, but still on the list. Diet and exercise, or diet, I should say. So certain foods are bladder irritants. So caffeine, alcohol, spicy food, acidic foods, those are all bladder irritants. So if you have underlying stress incontinence, those can make the incontinence a lot worse. And then very rarely, or at least in the population, injuries to the spinal cord can cause stress incontinence as well. Now, mixed incontinence, like I had mentioned earlier, it's a combination of the two. And a lot of people will actually come into the office thinking they need surgery, or they need Botox, or they need spine stimulators, when actually they don't. And that's why I really, and myself, Dr. Shu, Dr. Choate, we all do incontinence here. And one of the things that we try to do is, one, hear your story, but also help, guide you along the way. We're not just going to recommend one thing. We'll recommend a whole slew of things, and we'll really tailor that treatment to you. And that's what's nice about being here at TUCC. But one of the things, again, I'll ask you is, what percentage is based on the stress incontinence component, and what component is on the urge incontinence component? Because a lot of times by treating one, the other sometimes gets better on its own. So treatment options, probably the main reason that many of you are here today. Let's talk about different options. So, one of the things that I mentioned earlier was wearing the incontinence as a badge of honor. Fewer than 50% of women with incontinence actually seek help for a variety of reasons. Maybe they're embarrassed or ashamed, or they think it just has to be this way. And I'm telling you, it does not have to be this way. So always bring it up with your doctor, bring it up with us here at the Urology Center, bring it up with your primary care doctor, because there are great options available. So in terms of the options, we'll start talking about urge incontinence first. So remember, urge incontinence is that type of leakage where all of a sudden you have to go and then you can't make it to the bathroom in time. So for the most part, urge incontinence does not require surgery to fix it, but in extreme cases it can. So my goal is always to get someone dry, or as dry as they'd like to be, with the least aggressive approach. And I think going through the urge incontinence treatment pathway is helpful for this, because we really start with minimally invasive approaches, but we also have more invasive approaches. So the first thing we always try to recommend are lifestyle changes. Pelvic floor physical therapy can be very helpful, and diet changes. Just like people get physical therapy for their spine if they've had trauma, we actually have targeted bladder physical therapy that increase pelvic floor support to help with the urge incontinence. Also things like eliminating, caffeine or alcohol, spicy foods, things like that. The problem is all the things that we like to eat are the things that trigger a lot of times incontinence. The morning coffee, very common for people to say, I have my 2 cups of coffee in the morning and then I'm running to the restroom every 15 minutes. So that's very, very common. Other than physical therapy, we can do biofeedback and then also oral medications. There are about a half dozen oral medications on the market that are excellent at helping treat urgent incontinence. Some of the more common examples would be Vesicare, Myrbetriq, or Ditropan. They're all excellent. They all have slightly different time frames at which they start working, but for the most part, they really help relax the bladder. And I think, it's important because what your bladder wants to do at all times, everybody's bladder, it is designed to squeeze. That's all it wants to do. And the reason that we're all not just peeing ourselves all the time is your brain sends a signal that says now is not a good time to urinate. But sometimes that signal pathway, it gets a little bit off, and those medications help relax the bladder. So a lot of times we'll start off with pelvic floor therapy, trying to avoid some of those bladder stimulant foods, and then start oral medication. And that works for maybe 60 to 70% of women. But what about for people that don't have an improvement? So we have options for you. 2 of the most common options would be Botox injections or tibial nerve stimulation. So just like people get Botox in their forehead or different parts of their body for cosmetic reasons, Botox relaxes muscle. It can relax bladder muscle. The bladder is a muscle. So if your bladder is constantly spasming, the Botox can be very, very helpful. And while it may sound intimidating, it's actually about a 5 to 7 minute outpatient procedure under some light sedation, where we put small amounts of Botox in the bladder so that you can basically have improved continence. The other option, even less invasive than that, is what's called tibial nerve stimulation. So the S3 nerve coming out of the sacrum is really important for continence. It's the nerve that when it gets aggravated can cause more leakage. So tibial nerve stimulation actually involves accessing that nerve's ability to help us. So there is a small area in the ankle that has a nerve that goes all the way up to the spine that interacts with that S3 nerve. By actually putting a very tiny needle just underneath the skin in the ankle, we find that we can actually quell or de-stimulate that nerve to help with the incontinence. And it's excellent. Doesn't work quite as well as the Botox injections, but works pretty darn well. The other option, if those 2 things don't work, is what's called InterStim. InterStim, or a sacral nerve stimulator, is actually, again, utilizing that power of the S3 nerve root. We actually put very small electrodes near that nerve root in the back to directly inhibit that nerve. That's done through about a 1 hour outpatient procedure, so it does require anesthesia, but women are very, very happy because they have great results. The batteries they can last up to about 10 years. So sometimes we have to put a new battery pack in if it stops working, but people do really well with that procedure. But again, we could fix almost everybody with surgery, but at the same time, if we have options that are good, that are less invasive, that's what I'd like to really start with most patients. So that's the treatment for urgent incontinence. And actually, one of the questions that just came up was about Botox, which is about how long the Botox treatments will last. And I actually probably should have addressed that. So the answer is it depends. And most people have a good response from the Botox injections for at least 3 months. I've seen it last up for about a year. So the way that we do it is we do the Botox injection. You go home that day. And then over the next few months, we see how you're feeling. We make sure that you're still emptying your bladder well. And then your body actually tells us when the next time for the next injection is. So let's say, for example, that we do an injection in March. You might get a durable response all the way through September or December. Now, obviously, we can never quite tell how long it's going to work because everybody's metabolism is a little bit different. But for the most part, we can count on at least 3 to 6 months. Another question that just came up was talking about the pros and cons of each medication. So when we look at the medications, there's really 2 different classes. There's anticholinergics and then non-anticholinergics. So medicines like Ditropan, Vesicare, those are all kind of in one category with the anticholinergics. Myrbetriq, a little bit newer medication, is in a different class. It's a beta-3 medication. So for medications like Ditropan, Vesicare, the real advantage to those medications is they work very, very quickly. We can give patients the medication on a Tuesday, and they're seeing a response by a Wednesday or Thursday. Now, the downside to those medications is that while they're fast on, they can also have side effects. So anticholinergics can cause side effects such as constipation, dry eyes, dry mouth, things like that. So sometimes the side effects are actually the rate limiting step for us. And now we can decrease the dosages as well. Some people just don't have a good response because of the side effect profile. So it's actually not uncommon to change medications if somebody has a reaction to one but not another. Another, like I mentioned, Myrbetriq, one of the beta-3 medications, it works a little differently. So it does not have, Myrbetriq does not have the same side effect profile that those other medications have. So the only thing that Myrbetriq really does, it can cause a little bit of indigestion, but it can also raise the blood pressure by a couple points. So for people with poorly controlled diabetes, or poorly controlled hypertension, we don't usually want to use Myrbetriq. So the big advantage is really the side effect profile. The disadvantage that we see with Myrbetriq is that it can take several weeks for the medications to start working. So if I have a patient that comes in and they say, listen, I need to do something now, and we want to do a medication, I'll usually start something like Ditropan first. Whereas if a patient has more mild symptoms, I'll usually start Myrbetriq first, knowing that we have a 2 or 3 week ramp up period before we get a maximal effect from that medication. And there's actually a question earlier as well I wanted to address. What is biofeedback? So the best way to describe biofeedback is your ability to understand what muscles in your pelvis help control your ability to stay dry. So the pelvic floor, it really contains many muscles. And what we can actually do is they put small little, just like people have EKGs and they have little electrodes on their chest, we actually can put small electrodes near the pelvic floor to tell us which muscles are involved in keeping you dry. And then we can actually simulate leakage and actually teach you how to keep yourself dry through the biofeedback. So I hope that answered that question. In terms of treatment options for, or actually one just came in for physical therapy as well. So physical therapy, at least in the Denver area, there are several companies that do it. Typically, you go in for an initial consultation with the physical therapist, and what they gauge is really your pelvic floor issues. Perhaps one of the issues with urine incontinence is you can't, get to the restroom quickly enough, or you can't hold it. They can actually teach you holding behaviors or quick flicks in order to get you safely to the bathroom so you don't wet yourself. They can do pelvic floor strengthening, whether that's through Kegels or other exercises. They also do things that are non-incontinence based as well. So women or men with chronic pelvic floor pain, pelvic floor spasms, pain with intercourse, things like that, they're also really good at treating them as well. But for incontinence, a lot of it is about strengthening the pelvic floor. So in terms of stress incontinence, again, stress incontinence is that leakage with cough, laugh, sneeze, or some sort of stress. There are both surgical options and non-surgical options. So in terms of non-surgical options, stress incontinence, pelvic floor therapy is excellent. Again, strengthening that pelvic floor, those Kegel exercises that we read about. Actually, one of the patients, they told me the way they describe Kegels as if I had to hold a ping pong ball in my vagina. And I was like, that's a really good way to describe it. And that's really what Kegels is about, being able to support the pelvic floor so you can gauge those muscles. Physical therapy and biofeedback, again, involved in minimally invasive techniques. And then also vaginal pessaries. So a pessary is a flexible piece of rubber or plastic. They come in tons of different shapes. Pessaries go inside, just inside the vagina. And actually, if my finger is the urethra, they provide direct support on the urethra so that urine cannot come out. Many women have excellent experiences with them because they don't require surgery and they can use them or not using them depending on how you're feeling today. In terms of surgical options, there's really, well, actually what I'll go is I'm going to go more in depth into the minimally invasive options. I listed true surgical options. I can't remember the last time I heard anybody have a Marshall Marchetti Krantz procedure. most of these options aren't really used anymore because the minimally invasive options are just excellent. They're so good. They're safe, and women have great results. And the two main minimally invasive surgical options are injectable bulking agents and tension-free vaginal tapes. And I'm going to go into each one of these. So injectable bulking agents, essentially, if you think of the urethra like a tube, the tube has stopped working and urine is just coming out of it. A bulking agent is really a gel-like material that gets injected near the urethra or the bladder neck to support that area. Almost think of it like a dam. Now, the dam doesn't always last forever. And that's one of the big complaints about urethral bulking agents, is that women get, a good response for a year or two, but ultimately that agent can move, or in some cases, it can actually be extruded out of the body. But for the most part, those agents stop working over time. But they're a great option for somebody that has really mild symptoms or wants the absolute least invasive option available to them. And this is what the next part is going to talk about, are mid-urethral slings. And the urethral sling is really the gold standard for treatment of stress incontinence. And they are excellent. Some form of mesh slings has been used since around the 60s. And in the US, some of the more recent slings have been on the market since the late 90s. I wanted to take some time to talk about mesh because in a lot of ways, mesh gets a very, very bad rap. And if you put mesh into Google or do a search engine, there are going to be tons of horror stories online. And the truth is, many people have been harmed from mesh. But it's more dependent on the location of the mesh more than the mesh itself, because all mesh is basically the same. It's some form of an interlaced, polypropylene or nylon component that essentially helps support an area of tissue. So for example, if people get large hernias in their groin or their abdomen, surgeons will put mesh in to essentially hold those abdominal contents back. And we don't see a lot of complications from abdominal wall mesh. You can, but it's pretty rare. Where there were problems with pelvic floor mesh and vaginal mesh really came for two reasons. You had people putting mesh in the pelvis that truthfully probably shouldn't have. And that's been fixed for the most part. And we also found out that mesh just did not work very well in the vagina to support, to really anchor up those areas. Now, the urethral mesh, while it's the same product as people typically use in the abdomen or what used to be used in the vagina, it's a different location. And those vaginal mesh kits that caused a lot of damage and a lot of harm aren't even available on the market anymore for the most part. But the urethral sling, which is a very thin piece of urethral mesh, goes actually underneath the urethra. So it's not really considered a piece of vaginal or prolapse mesh, which is good news. So in terms of the procedure, the real benefit of the sling procedure is the durability. And, we quote people typically 90-95% success rate. Over time, over a decade or so, if the urethra atrophies a lot, the mesh may not be as solid. We can always put a second piece in, but people are very, very pleased with the urethral mesh with the slings. And I always tell my patients that the two happiest patient populations that I work with are women with stress incontinence that get mesh slings, and men that have their prostate removed for enlarged prostate. And I do both of those procedures, and those are always the happiest patients. So whenever anybody comes into the office, complaining of stress incontinence and they're interested in a sling, it's one of the best feelings because I know that we're going to have a good outcome. This is a diagram of essentially how the mesh sling works. I think three-dimensional photos are difficult. Again, if you think of my finger as the urethra, the mesh sits just underneath the urethra to help support that area. So again, I used that analogy earlier about the garden hose, right? If you're in mud, the hose just sinks right into the mud, keeps squirting everywhere. But if you're on firmer ground, that pelvic floor can contract and hold that urine in. And what that mesh sling does is it helps provide solid ground for us, which is very, very helpful. There are different surgical techniques for it. There's different lengths of the slings that people use, but essentially they all do the exact same thing. Somebody asked a question recently, any of these not good if you get kidney stones? I assume this is related to the medications for urge incontinence. And what I'll tell you is there's really not an association with these medications and stones. I will say that women that leak tend to be afraid of drinking a lot of water, because the more water you drink, the more urine you make, the more urine you make, the more leakage you have. So we know that for kidney stones, because I do a lot of stone surgery as well, that dehydrated people form stones. So the more dehydrated you are, the more stones you can form. So actually treatment of incontinence helps because people feel more empowered to drink more fluid. On to the next point, which is about treatment options for both. And I alluded to this earlier. The basic idea is if you come in with this mixed incontinence, 80% stress, 10% urge, maybe 10% unaware, our goal is to fix the predominant type of incontinence first. So, a lot of times just fixing urge incontinence, giving Myrbetriq or Vesicare or pelvic floor therapy, sometimes the stress component goes away. In a reverse scenario where you have 80%, say, stress incontinence, you're just always wet when you go to the gym. A sling or a bulking agent is really going to be one of the best options for you. In terms of, what people can do moving forward, the most important thing you can do is tell your doctor, whether you're seeing, a urologist here at the Urology Center of Colorado or your primary care doctor, tell somebody, because by telling them, it starts the whole process. And it doesn't have to be this badge of honor that you wear all the time. We can fix this for you, usually through non-surgical, sometimes even non-pharmacological methods. There's a great resource online, www.chooseyou.com. It has excellent resources, materials, success stories from people, but also goes into some of the downsides of treatment too. I think it's always good to have a balanced approach when we look at a lot of these different treatment options. I always tell people, beware of the person that wants to take you to the OR that day. They're not necessarily giving you all the options. And my approach, I know the other doctors here that do incontinence with women, our goal is to give you the whole spectrum of different options. Some people want to be more aggressive right off the bat, and that's absolutely fine. But there's no reason to be aggressive with treatment if we can get away with something that's less aggressive. Now, we may ultimately need something that's more aggressive in the future, but again, my goal is always to get you dry with the least aggressive approach. And that's, I think, a good technique. So I wanted to, take the time to open up to any questions. I know we've addressed several. Please feel free to use the question and answer tab on the side. It seems like people have a pretty good idea of how to use it because questions have been coming in. But actually, there's even more. I had to scroll down. Sorry. So the next question on the line here was asked about the recovery time on a sling. So I typically tell people, plan to take about a week. The truth is that you're up and walking, eating, drinking the day of the procedure, but like any procedure, it's a general anesthetic. You need to have somebody to go home with you that day, but people are feeling pretty darn good. I do typically recommend abstaining from intercourse for several weeks after the surgery to let the incision heal. And again, eating a good balanced diet. Your body is going to heal this tissue. So good calorie intake, good protein, good carbs, good fiber, treating your body well is going to help you recover. The full healing time is about 4 to 6 weeks for the incision to gain full strength. So I usually tell people, plan for a week, to take time for yourself, and then the full healing again about 4 weeks afterwards. The next question we have is, can a fan and steel incision or surgery for uterine fibroids contribute to urge and stress incontinence? The answer is yes. So, so just so people understand, so a fan and steel incision is an incision in the lower abdomen, it's usually about that long, right around the underwear bathing suit line. It's one of the more common incisions used for C-sections and also for pelvic surgeries. So the incision itself usually doesn't cause stress or urge incontinence, but what comes next can. So for example, removing the uterus, removing ovaries or large fibroids can disrupt the pelvic floor and the support of the pelvic floor. So by losing that support, again, that network of muscles has less support, that increases the risk of incontinence. Other reasons from surgery causing incontinence would be some suture that surgeons use in the pelvis can irritate the pelvic floor and cause those issues. But for the most part, it's just the loss of pelvic floor support. Let's see. The next question is, do you have female doctors that specialize in these treatments and surgeries? Yes, we do. So Dr. Kara Choate is a urologist in our group that does do female incontinence surgery. She's available for consultation. There are also numerous other providers in the Denver metro area. And actually on the Urologist website, there's a list of doctors as well. Here is another question. Occasionally, I feel no urge to urinate until I drive into my driveway, and then I cannot control the urge to go. Or I'm fine until I start to unlock the door to my house and I can't make it to the bathroom on time. Why does this happen? So, you know, the truth is a lot of times when people go home, they get into their car from work or from the store, and their bladder is probably ready to go, but they want to make it home. And then you have this mental association, I'm getting close to my bathroom, and your body knows it's about time to go to the bathroom because you're planning on doing it. And you can actually have bladder spasms because of that. So, you know, again, there's not a true define, but it's more of a psychological issue. Again, not in a bad way psychological, but just your bladder knows when it's home, and when it gets home, it knows it's time to pee. We provide, oh, sorry guys. Oops, one moment. Let me scroll down. Sorry, I'm having a little bit of trouble with the question and answers tab. Somebody asked, are we going to be recording this? Yes, and it will be available on the website. And then one of the other questions that was asked, are there any age limitations on any of these methods? So the answer is really, there's no age limit per se. But for example, with some of the surgeries, while they are usually short outpatient procedures, for people that just can't have anesthesia, that would be potentially a reason not to do it. Most people that have any heart and lung issues, if they still wanted to do the procedure, we could do it, but in a hospital-based setting. Most of these are done in the surgery center type setting, but there's real no age contraindication. Again, the goal is to do the least aggressive treatment first. So let's say, for example, I had, you know, a 90-year-old woman come into the office that had had 4 heart attacks, used 4 liters of oxygen just to get around. I would definitely have some hesitancy putting them through a surgery. I would want them to probably try a vaginal pessary first, or a urethral compressive device, because if we can get the same outcome with the least aggressive approach, that's really the best way to do it. While surgery is low risk, it's not no risk. And while urinary incontinence, for example, while stress incontinence is a very bothersome condition, it's not medically dangerous. Now, that doesn't mean it's not bothersome, but it's not medically dangerous. And the last thing you want to do is take somebody for a bothersome condition and turn it into a real medical condition. Because again, while these procedures are low risk, they're not no risk. I've never had somebody have a major complication after a sling surgery or an incontinence surgery, but having anesthesia, having the procedure, post-operative discomfort, those are all potential issues. So it's important to really weigh the pros and cons before any procedure. What are the side effects? The next question came in, what are the side effects of Botox treatment? So that's a great question. So when you think of Botox, the way the Botox is administered, after you have some sedation and are very comfortable, we take a very, very tiny telescope and actually go through the urethra to the bladder to look at the bladder. So by just introducing a scope into the bladder, there is a risk of infection. That risk is extremely low. We always give you a dose of antibiotics before the procedure, but one of the side effects could be potentially urinary tract infection. We typically put anywhere from 5 to 10 units of Botox into 10 to 20 different locations in the bladder. Most people will have a very small amount of blood in the urine for a few days. It typically gets better with just hydrating. The other side effect that we can potentially see is the Botox works by paralyzing the bladder. And while 100 units is usually the standard dose, sometimes that's too much for patients. And what can actually happen is the bladder will not completely empty after a Botox treatment, in which case we sometimes have to teach a woman how to self-catheterize for a couple weeks while some of that Botox wears off. From experience, what I can tell you is that I think we see more of those complications with Botox if we're jumping at Botox too quickly. So not trying the pelvic floor therapy, not trying the medication, because at least from my experience, if you have a woman who has an excellent benefit from a low dose of ditropan or a low dose of Vesicare or Myrbetriq, and then you give that same woman Botox, the Botox is probably going to be too strong. So I think a lot of it is actually selecting the appropriate patients. I hope that answers that question. Another question, I often feel flushed immediately prior to needing to urinate. Any medical hormonal explanation for this? Thank you. So that's a tough question because truthfully, probably needs some more information and really a good history and physical examination. More than likely what's happening is that you're having what's called a vasovagal response. So when you go to urinate and people, squeeze their bladder gets really full, sometimes they'll actually send a message to the brain and the heart rate gets going and the blood pressure can actually drop. And when the blood pressure drops, all the blood vessels dilate and you can actually kind of feel that flush sensation. That's what I suspect is going on. Obviously, we'd want to rule out any other type of metabolic issue with some blood work and a good examination, or a thorough examination, I should say. But it sounds more like a vasovagal response. Good way to potentially help that would be not to push and to really urinate on a time schedule. So not letting your bladder get really full, but urinating every 2 hours or so on a time schedule. Is it normal to get up to urinate during the night? So again, that's a pretty open-ended question. The answer can be yes, can be no. It depends on the person. Some men will get up 4, 5, 6 times a night to pee because of enlarged prostate. Not uncommon for women to get up at night as well, but usually it means there's some sort of underlying condition going on, and it can be as simple as a shy bladder or an overactive bladder. Any type of irritation in the bladder can also cause people to get up at night to urinate. So one of the more common things we see is people go to bed right before they go to bed, they drink 2 glasses of water, and then for those first 4 hours of while you're sleeping, your kidneys are still functioning and actually dumping a whole bunch of urine into your bladder. So one of the quick and easiest ways to help with getting up at night to pee is to actually limit fluids 2 to 3 hours after bed, just before you go to bed, and then urinating just before you go to sleep. That can help. Other causes, there's a half a dozen options. Like I mentioned, overactive bladder, urgent incontinence, small bladder stones can also cause it. If paired with, blood in the urine, potentially bladder tumors or bladder cancers, although that's much rarer. If you ever see blood in your urine, please call us here. That's a reason to come in, that week. We'll get you in as quickly as we can. I hope that answers the question about urinating, getting up at night to pee, but there's so many different reasons. And really, again, a good thorough examination, potentially a little bit of blood work, and then actually avoiding diarrhea can be very, very helpful. Next question. Oh, actually, this one's just a feedback question. It's not actually a question, but that's okay. Thank you for that. Thank you for that feedback. I appreciate you being here. So I don't see any other questions listed.
Dr. Drew,
so, yes.
You had one other question in the chat, and it was, is this considered elective surgery?
Oh, I missed that one. I would so for example, slings and the injection agents, I would consider them to be elective surgery in that, so that's a great question. So elective surgery is defined in a lot of ways, I should say. So for example, cancer surgeries, not really elective, not necessarily urgent or emergent, but not elective. These are, for the most part, elective surgeries in that, you know, for example, during COVID, during the peak of COVID last summer, I had to delay patients to have the surgery because, you know, we were not allowed to put people under anesthetics for this type of surgery. Those restrictions have been lifted. We're doing these procedures now, but just like most surgery, I would consider sling surgery or bulking agents to be elective, in that leakage will not kill you, if that makes sense. They're not elective like a lot of cosmetic surgery, but they are still considered elective surgeries. It looks like another question came in. Will the InterStim help with leakage in working out? I would say for the most part, no. There are some women that have what's called urge-induced stress incontinence. So what'll happen is their bladder will get really full, and then that will actually, when their bladder gets really full, almost like a pop-off valve, they'll leak some urine out. So if you have InterStim and you have that stress and that urge-induced stress incontinence, it's possible it would help. But usually if we see people that have an InterStim that still have stress incontinence, a lot of those women do end up getting slings or bulking agents, mostly slings, because, you know, urge incontinence and stress incontinence, while it's all leakage of urine, again, they're very different in how they're treated. And for the most part, stress incontinence will not be helped, because leakage with working out tends to be the type of leakage that's stress, that is stress incontinence. Any other questions that I can answer for any of you tonight? Well, I'm gonna take that as a no unless any come in the next few minutes. Thank you for being here. I think that it's one of the most underdiagnosed issues that I think we see in the community. And again, it's very, very treatable. So I encourage you, talk to your primary care doctor, talk to your friends. I think that one of the things that people don't do is, because there is a degree of embarrassment about it, people don't talk about it. And luckily people are talking more about it now than ever, but still not that many people. So I think talking to your friends, talking to your family, talking to your doctor, and realizing that you're not alone in this. It's so common. I mean, if you're in an auditorium, odds are that somebody next to you has this exact problem. So, please reach out for help. We're here to help you here at the Urology Center. We have several specialists that help with this. And I'm happy to see you anytime in the office. It looks like maybe one more question came in. Oh, no. I made a mistake. It's not a question. All right. Well, thank you so much for being here. And I hope you all have a wonderful Tuesday evening. Take care.